All right, so we'll start off Nutrition and Disease 2 with our first lecture, which is going to be psychiatric conditions. All right, so a little bit about psychiatric conditions. So these are disorders that involve altered brain or nervous system function that may result in altered perception and response to the environment, so also referred to as mental illness. And so more than 450 million people with mental, neurological, or behavioral problems throughout the world. So we'll dive into neurological disorders as a separate lecture. So this lecture that was focused on psychiatric disorders. But so 1 in 4 will suffer from mental illness during their lifetime. And so again, we'll talk about the fact that, right, some of these conditions are transient. That is to say that they come and go. Some are permanent, some are temporary. So we're going to talk more about that. Now, what we will talk about is that, of course, again, our main role is looking at how nutrition plays a role, and so that's usually in a function of rehabilitation for mental health disorders. And again, the most common mental health disorder that we're thinking of with nutrition is going to be eating disorders, but really all mental health disorders, and then we'll also talk about neurological disorders in a following lecture. So when it comes to the diagnosis of mental health disorders, right, we are now on the DSM-5, or the Diagnostic and Statistical Manual, the 5th version or the 5th edition. And so this contains a list of all psychiatric diagnoses with their corresponding diagnostic codes and criteria. I recommend that you never ever read the DSM-5, as you will begin self-diagnosing yourself with everything under the sun. Now what I can tell you is that looking at mental health and psychiatry is a lot the same way that looking at nutrition. It's a lot of science, but there's also an art to it. And again, I know you're tired of hearing this, but looking at mental health disorders, right, the famous statement is, how do you know the difference in art and porn? And the answer is, you'll know it when you see it. And that is, right, a trained mental health professional, right, you'll know it when you see it. And so no offense, but we are not trained as mental health professionals. So again, please don't try and self-diagnose. I know we're all kind of in this quarantine right now, so don't try and diagnose your family members that you're stuck with. You just realize it is more complicated than that, right? The criteria is there and then has to be interpreted by a professional. Now looking at a psychiatrist versus a psychologist, and again, so for the types of disorders we're going to be discussing in this lecture, the treatment may include both. But predominantly, right, the practice of psychiatry and psychiatrists is they can prescribe medications, as they are also a medical doctor, whereas a psychologist, right, especially a clinical psychologist, has their PhD or their Psych D. So what it is, they're trained in psychology, which is a treatment method using psychotherapy or talk therapy. And again, usually these patients are using some combination of both therapies. So let's take a look at, this is just a brief list of psychiatric conditions that have nutrition implications. This is everything including autism, ADHD, bipolar disorder, borderline personality disorder, dissociative disorders, eating disorders, major depression, OCD, panic disorders, PTSD, schizoaffective disorder, schizophrenia, seasonal affective disorder, suicide, and Tourette syndrome. Now, looking at the broad umbrella, so the American Psychiatric Association classifies disorders into 2 major categories. So we have Axis 1 and Axis 2. And so Axis 1 typically do not improve without medication. These can be degenerative and permanently destructive without treatment, versus Axis 2 disorders are personality disorders, and they do not respond to medication. So that is just to say, right, is that you are who you are, and then, right, and so whatever causes or causes this to happen, or whatever development in the brain, but there's no going back. You is who you is, and that's just the way it is. So Axis 1 disorders, these include things like depression, anxiety, OCD, bipolar disorder, ADHD, schizophrenia, PTSD, eating disorders. So these are all things that you may think of common in your head as quote unquote having a cure. Now again, I add that words in quotes because it's a little more complicated than that. But right, these are diseases that they have a treatment. It's usually pretty well defined. You're probably pretty familiar with, right? So depression, we have antidepressant medication. Anxiety, right, I'm sure everybody is familiar with by now, with benzodiazepines, Ativan, Xanax, etc. Similar to OCD, ADHD, I'm sure everyone's familiar, right? There's an entire family of drugs for treating ADHD. So again, we looked at that definition of Axis 1 disorders and improvement with medication, but also very dangerous and degenerative without treatment. So Axis 1 disorders are diagnosed through behavioral criteria and psychological testing. Now, there's no definitive diagnostic testing. So again, and what that means is that there's no blood test, right? So I can't give you a blood test, come back and go, poof, you've been infected with ADHD, right? That's not how really any of these disorders work. But again, what we're looking at is with that diagnostic manual and with a trained clinician, we kind of have some idea and can make a definitive diagnosis. Now, altered food or eating behavior can be one of the first indications or symptoms of an existing disorder. Again, not the cause, but again, something that happens at the same time or a comorbidity, right? So we may see a change in intake, etc. And so, for example, we would consider an Axis 1 disorder when an individual is trying to follow nutrition recommendations, but seems to be driven to behaviors that are counter to those intentions. So, for example, with ADHD, for example, right, they lack impulse control. So again, they want to make better dietary choices, but then they fail to, right? Then they have poor impulse control. So again, that's an Axis 1 disorder interfering with a nutrition intervention. Axis 2 disorders, these are things like antisocial, narcissistic, histrionic, schizoid, avoidant, dependent, and borderline behavior. So again, these are personality disorders, and so again, if one of these develops, you is who you is, and that's just the way it is, right? There's no changing that. So again, once this has happened, now there are coping strategies, right? There is treatment, but quote unquote, right? There's no cure. You are who you are. So Axis 2 disorders may be more appropriately termed as adaptation disorders. So again, this includes personality disorders and intellectual disabilities. And so again, that is to say that there is no cure, there's no undoing them, but there is coping with them, right? And developing strategies or a lifestyle to manage them. So these usually first arise during childhood. So psychotherapy is required to achieve symptom relief. So again, we're looking at treatment and how to change our own behavior. But again, it doesn't just go away. And so autism and mental retardation are also considered to be Axis 2 disorders. Now, what we also have is comorbidity. And so again, as a concept from mental health is the fact that Axis 1 and Axis 2 disorders are often comorbid conditions. So they exist simultaneously, but independently of other medical conditions. Or someone may develop an Axis 2 disorder as a coping mechanism for an untreated or an unresolved Axis 1 disorder. Now you'll see that this is a recurrent theme as we talk about nutrition for the brain and nervous system. So you'll see this again, especially when we talk about other disorders. So omega-3 fatty acids, again, preferred fatty acid in the brain and incorporated in the nervous system with a focus on specifically EPA, that's our eicosapentaenoic acid, and DHA, that's our docosahexaenoic acid. And so these show promise in the treatment of psychiatric disorders. So we know that DHA is required for normal brain growth, development, and maturation, and EPA intake is important for general mental health. So you'll see that DHA is a big focus now on many children's products. So you'll see that it'll be included in children's multivitamins and infant formula. It will make sure to make mention of the quantity of DHA, again, because you're looking at brain growth. Again, our sources for omega-3s, so again, our cold water, deep sea, that oily or greasy fish, right? That's going to be your salmon, tuna, and sardines are good quality sources of EPA and DHA. EPA and DHA may help with postpartum depression. And we do know that breast milk does contain EPA and DHA, which is why infant formula is fortified to mimic, right, those same quantities. So again, that's why you'll see that formula is fortified so it has EPA and DHA added. And some studies show that there may be a benefit with ADD and ADHD, again with the inclusion of omega-3 fatty acids. So here you can see a list of conditions with which EPA and DHA have benefit. So anxiety disorder, ADHD, autism, bipolar disorder, depression, dyspraxia, eating disorders, postpartum depression, schizophrenia, and suicidal ideation. So again, you can basically see that there almost isn't anything that EPA and DHA don't help. And again, with the exception of some bleeding risk, which is usually going to be more prominent in the elderly or high doses, where there's very little side effect to this omega-3 intake. So nutrition for the brain and nervous system. So again, continued, and we'll talk about those just some interesting correlation. But so lower seafood consumption associated with increased rates of depression. Now that is an association, that's not causation, but it's interesting. And omega-3 is often provided in conjunction with antidepressants. Omega-3s may help maintain cognitive function. We'll talk about that in the neurology chapter as well. And the current recommendation, right, is that we have a fish intake of at least 2 times a week, and with a minimum intake of 500 milligrams of EPA and DHA per day. And so there is an interesting New York Times article. So does eating salmon lower the murder rate? So there's increased rates of homicide associated with that lower seafood consumption. Now again, we know that correlation can show us some interesting things, and there are some correlations that can be made when there's actually no causal relationship. But it is interesting when we take a look at mental health and omega-3 intake. So individuals with mood or psychotic disorders may benefit from omega-3 supplements. So these are best absorbed with a fat-containing snack or meal. And what we see now is an increase in the fortification of foods with omega-3s. So for example, I don't know if anyone's paid attention or who does the grocery shopping, but you may have seen omega-3 fortified eggs. So don't worry, they're not injecting your food with anything. What they actually do is you feed the chicken flax, and then that actually increases the omega-3 content of the egg. So again, we can see the classic recommendation of fish 2 or more times per week. Individuals with mood, impulse control, or psychotic disorders, so 1 gram or 1,000 milligrams of EPA and DHA per day. So again, that's doubling it from the previous recommendation. And then patients with mood disorders, again, somewhere between 1 to 9 grams of EPA and DHA per day. But more than 3 grams per day should be monitored by a physician. And so more than 3 grams per day actually increases your risk of hemorrhagic stroke. So we'll talk more about that in the neurology chapter. But again, I'm sure you've heard that omega-3s are good for cardiovascular health. And that is true to a point, but more than 3 grams per day actually increases your risk of a subcategory of stroke, which actually increases the risk that you might bleed too much. And so here we can see, again, this is correlation, not causation. But what's interesting is that we see some major depression, so annual prevalence rate per 100 people, and apparent fish consumption in pounds per year. So you can see that, for example, so Japan has a very, very low depression rate and a very, very high fish consumption rate. The United States has an increased rate of depression and much lower fish intake. Again, though, there's a lot of difference between these cultures. This is just correlational, not causation. But again, it is very interesting. So again, we said that especially for people that are having psychiatric or mood disorders, we're going to look at having to increase this. So we know that everyone should be getting that fish twice a week. But then we said, right, it went up to at least 1 gram a day, and then somewhere between up to even possibly 9 grams a day, which again, I don't know about your budget, but I can't afford that much salmon. So, right, we're looking at supplements. So EPA and DHA are available from fish oil. And then as a very, very budget-friendly source, you have cod liver oil. We said these were best absorbed when consumed with a fat-containing meal or snack. Now the problem is that you may have noticed is that if you've taken fish oil, especially when you're taking large quantities of fish oil, then there's usually poor patient compliance, right? Which is the patient refuses to take it either because it's difficult to swallow so many gel capsules because they're so large, or more frequently because of the reported fish burps or the aftertaste, right, from consuming such large quantities. Now, the higher quality omega-3 supplements will usually contain an antioxidant such as vitamin E to help stabilize and preserve them. The other thing that you may see or recommend is that patients or clients keep them in the freezer. So it actually reduces the fish burps, and that actually also helps with preserving and protecting the long-chain polyunsaturated fatty acids. And again, we've talked about the increase in fortification of foods. Looking at other nutrients of interest for the brain, we've talked about this a little bit previously, but looking at an importance of vitamin D. So we've talked previously about autoimmune disorders, but we also know that it plays a role in brain health. So studies show that vitamin D deficiency is associated with the presence of mood disorder and an increased risk for depression. Now remember that vitamin D can be synthesized from sunlight. So if we have a functioning liver and kidneys and we get adequate amounts of sunlight, then we can get adequate vitamin D. Now again, most people that are going to be at risk is going to be people that live further north, so people in New England, people that live in large cities where it's actually difficult for the sun to penetrate and hit the ground. The other major concern is that in this modern society, or especially in Florida, is that we have plenty of sun, but no one actually spends any time in the sun. So when you think about it, now I know, right, it may be a little bit different with your schedule currently, but normally if I had you in class right now, students would be wearing scrubs, with a fair number of you wearing a jacket and or an undershirt. So we have no sun exposure on our upper arms, no sun exposure upper chest, and then again, I'm sure that most of you, I don't know for sure, but I'm assuming that many of you wear makeup, and I don't know if there's a makeup brand out there these days that doesn't advertise being at least SPF 15. So we're of course wearing pants because that's obvious. We're wearing now a shirt and long sleeves, so we've got no sun exposure on our upper body, and we're now wearing makeup, so we've now got no sun exposure on our face. So now this is why you'll see that quote unquote there's this increase in this risk of vitamin D deficiency in the modern population. And so again, we live inside, we have air conditioning, we go from the building to our car as soon as possible, turn on the AC. We wear things that have SPF in them, we're concerned about skin cancer. We may have temperature control issues, so we're wearing a jacket. And all of a sudden, we're really not actually getting that much sunlight exposure. So again, I don't want anybody to go out and get burnt. Please don't do that. That's very bad for you. But again, so I've been trying to take advantage of at least getting, that 15 to 20 minutes of sunlight per day. So again, you're looking at upper chest, which is your shoulders, etc. So shoulders, arms, face, again, 15, 20 minutes, no more a day is all that's really needed. Or you can take a vitamin D supplement. So food sources include oily fish, egg yolks, and then fortified milk and cereal. And so again, recent studies are linking low vitamin D levels with increased risk for Alzheimer's, Parkinson's, MS, and schizophrenia. Looking at the B complex vitamins, so we know these have neurological effects, so they're looking at other effects on brain health. Sufficient intake is important for individuals with psychiatric disorders. And so again, remember, B vitamin deficiency can be linked to nerve damage, which is real technically in the category of neurological disorders. Again, this is irreversible if it goes on for too long. But then these patients may also need folate or B12 or an entire B complex. Again, some of the medications may cause an increased destruction or increased excretion of the B vitamins. Some sources for B12. Again, we're looking at, so we've had this discussion previously in class that food sources are going to be animal only. But again, there are natural plant-based supplements. So again, we've talked about green and purple laver. But again, according to the government, that's considered a supplement. So the foods are going to be beef, liver, clams, oyster, crab, tuna, halibut, etc. B6 is going to be found in beef liver, oatmeal, bananas, chicken, potatoes, avocado, sunflower seeds, brewer's yeast, halibut, pork, and brown rice. And folate can be found in brewer's yeast, mushrooms, spinach, broccoli, Brussels sprouts, asparagus, kale, and other greens, legumes, liver, and fortified into orange juice. Now we're also going to take a look at some phytochemicals just as a concept. So again, these are plant-based foods that contribute to normal brain function and mental health. Again, with a focus on antioxidant activity, again, protecting and preserving brain cell structure and metabolism. So we've got our three subclasses of flavonoids. So flavanols, anthocyanins, and flavanones. And so again, our flavonoid-rich foods are going to be things like apples, berries, dark chocolate, citrus, grapes, teas, and certain spices. So in addition to specific nutrients, we'll take a look at some side effects. So we'll take a look at specifically, there's a focus on weight management. And so these side effects have been known for about 30 to 40 years. And so psychotropic medications can cause rapid or excessive weight gain. So part of this is fluid retention from the actual medication itself and from its pharmacological effects on the body, where some are actually from a treatment of the disease process. So for example, depression often presents with poor appetite and unintentional weight loss. So if I then give you a medication and now you're no longer depressed or you're less depressed and you eat more food and you gain weight, right, then you could say that the drug caused weight gain. But it didn't really, right? We're looking at treatment or resolution of the symptoms of the disease process. Additionally, other symptoms of depression, so for example, may lose interest in food, shopping, cooking, etc. And so again, what we're going to have is we're going to have malnutrition or a form of it because again, we're not taking care of ourselves, we're not eating as well, we're not buying as quality of food, etc. So again, we want to encourage physical activity and a healthy eating plan. And again, a kind of acknowledging and letting the patient know that some of this weight gain is normal, right? So again, it's not good or bad, unless our patient's already got an extreme weight issue, right? Something that's affecting their health, but realizing that our biggest focus is first going to be on treatment of having the psychiatrist and the psychologist treat those symptoms. Again, the weight management is going to come right as a side effect of that treatment. But again, what's most dangerous, what's going to harm the patient first, which is going to be the psychiatric illness, and then the side effect, right, the weight issues, depending on, like I said, unless there's any comorbidities or other underlying illnesses. So things to take a look at, and so again, it's a little more complicated than the media portrays it, but looking at addiction and substance abuse recovery. So addiction, so a chronic brain disorder that involves compulsive and relapsing behavior with biochemical, psychological, and social vulnerabilities, with dopamine, right, being our pleasure neurotransmitter, right, so looking at our molecule of addiction. And so poor diet and stress enhance, right, the problems of an addicted individual, so it makes it more difficult to manage. And again, so you look at those same behaviors, right, that compulsive behavior, again, that psychological behavior, that social vulnerability, again, goes hand in hand with an eating disorder. Now, again, the problem is so you might have heard of food addiction and realize, right, it's a little bit more complicated and it's not quite how it's portrayed, but for example, drugs have a physiological addiction, right? So when you're looking at your body actually becomes dependent on them. The problem with food is, right, you're looking at a psychological addiction. But the difference is that substance abuse, you can live without. So again, now, right, we're now in close quarters with family and trying to survive. But I assure you, you do not need alcohol to live. You do not need it, right? It's technically classified as a poison. You do need food to live. So for example, I do not think you could find a treatment plan anywhere that would say to an alcoholic, hey, it's okay, just have a little bit. But then we take patients that have eating disorders or binge eating disorders, etc. They still have to eat, right? You can't just, so imagine, right, oh, that thing that you're having compulsions over, well, eat just a little bit of it, right? That's not the discussion that we have. So it's a little more complicated when taking a look at substance abuse, but again, realizing that we want to make sure that we have a nice, right, level of physical activity. We want to have a proper healthy diet, right? We talked about our specific B vitamins, our omega-3s, right, and kind of making sure that, again, we have improved self-care when we have a treatment of these psychiatric conditions. So our goal, right, is to provide information and support for eating choices that minimize the effects of the illness on the client and their family. Again, realizing that when we're looking at our hierarchy of needs, looking at changing their diet significantly, may be pretty low on their priorities, so they may not readily adapt to changes. The patient may be overwhelmed, frightened, anxious, depressed, etc. We don't know if this is a new diagnosis, if this is a recurring diagnosis. Again, so looking at continued small improvements. But one thing to consider in the short term, so depending on your rotations, is you may have a behavioral health unit. And what we're looking at is what's known as suicide precautions, in which case, right, so we're going to have no glass, no porcelain, no metal, no knives, no bones, etc., etc. So again, it's going to be things for the patient's safety. Again, just to make sure that just in case, right, there's nothing the patient could use to injure themselves. So again, looking at nutrition and brain health and looking at some of the factors so we can see, right, we're looking at omega-3s, exercise, sleep, stress, antioxidants, B-complex vitamins, vitamin D, and phytonutrients. There's actually an interesting study, and so if anybody wants to talk more about exercise, we might be able to do that during one of our Zoom sessions. But so there actually is a study out of Duke that takes a look at exercise specifically with depression. So again, it depends on which specific psychiatric disorder. But again, they always say that, exercise is effective as medication. But then you read through the research and you realize these people are having to do some pretty intense workouts. So we can have a discussion if anyone is interested. Some possible diagnoses, so food and nutrition related knowledge deficit, harmful food, nutrition, attitudes, and beliefs, undesirable food choices, any specific deficiencies or inadequate intakes, imbalance, so again, not the correct ratio or not the correct amount of omega-3s, excessive carbohydrate intake, excessive intake of processed and refined foods, altered nutrition-related lab values, excessive or inadequate intake, underweight, overweight, or obesity, food-medication interactions. So pica is the persistent eating of non-nutritive substances for at least 1 month. So this can occur in conjunction with other disorders. It occurs more frequently in young children than adults. And so, for example, young children commonly ingest paint, plaster, string, hair, or cloth. Older children may ingest dirt, animal feces, stones, or paper. And so again, this may be one of the causes of lead poisoning, right? So ingesting paint chips, again, because of this disorder. So again, a compulsion to eat paint chips, which again, if it was lead-based paint, would cause, right, that damage from lead consumption. Now, pica can also occur during pregnancy, in which case there's usually one of two forms. So if you're geophagia, which is clay or earth eating, and then amylophagia, which is eating starch. Other substances, though, may include ice, paper, burnt matches, stones, gravel, charcoal, soot, cigarette ashes, antacids, milk of magnesia, baking soda, or coffee grounds. And there's a couple of theories for why this happens, especially in pregnant women. So again, is it because they're deficient in a micronutrient? Is it because it relieves nausea and vomiting? And the problem is we don't really know. The biggest reason is that we can't really run a lot of tests on pregnant women due to obvious ethical concerns. So we're really left speculating. So we're not really sure what causes this, other than, right, so for example, if it's ice, right, with the exception of the fact that it could be damaging to the teeth, relatively harmless, whereas something like excessive amounts of antacids, right, can be very dangerous. High level intake of baking soda, charcoal, soot, right, etc., all very dangerous. So again, it kind of just depends on the cause, if it can be controlled, etc. But there's really not a lot of testing or experiments that are safe to perform on pregnant women. So a lot of this is just theory. So again, we said those implications can be benign or life-threatening depending on the objects consumed. Again, in children, we talked about the risk of lead poisoning, anemia, intestinal parasites, intestinal obstructions, malnutrition. Again, severe iron deficiency may present with pica and that ice eating, but again, this is compulsive. So again, we live in Florida, and this is why I say do not attempt to diagnose yourself. Do not read the DSM-5, because again, we live in Florida. It's 100 degrees out. Eating the ice out of your iced tea is not because you have pica or because you have anemia. It's because it's hot and you're thirsty. But again, if it's a compulsion and you can't control yourself, and you have to, right, if you're constantly seeking ice, etc., then that's a bit more of a concern. In pregnant women, for example, we talked about that amylophagia, right, that starch eating. which again can lead to obesity and or looking at blood glucose control issues if the patient has diabetes or if they have gestational diabetes. Again, so increase, so this says blood pressure, cancer, pregnancy and delivery complications. Again, you're looking at total intake, specific substances, or weight gain from the intake. So the first thing we'll take a look at is depression disorders. So mood disorders in which the depression is unaccompanied by manic episodes, abnormal emotional state, characterized by sadness, despair, discouragement, feelings of worthlessness, and or hopelessness that are inappropriate to reality. It's severe enough that it interferes with daily life, and so fairly common. And again, so looking at major depressive disorder, for example, can be very serious. And so 1 in 20 people experience depression in the US, according to the NHANES data. Average age of onset for major depressive disorder is 40 years of age, affecting 10 to 25% of women and 5 to 12% of men during their lifetime, but with 50% of nursing home residents having a depression diagnosis. And so, for example, you can see that if loved ones have passed on, they're no longer able to take care of themselves, their independence is taken away, they're now living in a nursing home. Again, they definitely have the depression symptoms, but I think part of it is also, remember, is that we said on the previous slide, is that it's inappropriate to reality. And then again, it comes down to, well, how severe is that of a change in their lifestyle, etc. So maybe to them, it appears to be, a significant worse reality or a change in circumstance. Now again, we see with depression, so a change in brain chemistry, so this can be due though to genetics, traumatic event, hormonal shifts, change in health habits, or another illness or substance abuse. So again, we're looking at a change in neurotransmitter levels in the brain. Now looking at, so for depression, so things that are easy to remember, so we have siege caps, so sleep changes, loss of interest, inappropriate guilt, energy decline, concentration changes, appetite changes, psychomotor changes, and suicidal tendencies. So nutrition-related issues, so we've talked about this a little bit, looking at that family of drugs. So either increased or decreased appetite, so usually when people are depressed, they either eat a lot more or a lot less. So we see weight gain or weight loss depending on that appetite. Nutrition status may decline. We say that omega-3s, again, they're not a magic bullet, but they have a positive effect. Again, the side effects for those antidepressants was that weight gain, low serum folate, common in depressed adults, so again, looking at that supplementation of B vitamins, and again, encouraging physical activity. Now, again, it's a little more complicated. This is not a leisurely stroll. This was, you're at least into your 70% of your VO2 max for several times a week. So, not the most intense physical activity, but again, this is not just walking the dog. This is a little more intense. So treatments include antidepressant medication. Now there's a couple different families. So for example, we've spoken previously about MAOIs or monoamine oxidase inhibitors, such as Nardil and Marplan. And so again, this is where we have to avoid foods high in tyramine. So this is our old stinky foods. That's your wine, aged cheese, cured meat, sauerkraut, etc. And so again, here looking at a dangerous increase in blood pressure due to the pressor not being broken down. So it leads to a loop where your blood pressure gets higher and higher and higher, which can cause you to have a stroke or a coronary event. So you're looking at a type of heart attack. So more popular now than MAOIs is SSRIs, or selective serotonin reuptake inhibitors. And this is your family of drugs like Prozac, Zoloft, Lexapro, and Celexa. And then also some patients are going to be on tricyclic antidepressants, which again are a little bit older. The next disorder we'll take a look at is bipolar disorder. So this is a mood disorder characterized by manic episodes, usually in conjunction with depression. And so again, bipolar, so having two poles, So we're having large mood swings between manic episodes, where the patient is overly joyful, excited, or giddy, and then depressive episodes, with feelings of sadness and hopelessness. So again, likely genetic, again, though also having environmental factors and abnormalities in the brain chemistry. And this usually develops in the late teens or early adult years. So there's usually some kind of trigger, such as moving away to college, graduating from high school, intense testing, senior year, etc. But there's usually some kind of high stress incident that then is followed with these symptoms. So nutrition-related issues may increase or decrease in appetite. May develop obesity, again, due to the medications, right? So mood stabilizers are known for causing weight gain, overall decrease in nutrition status. Again, that's side effects of increased appetite due to medications. Omega-3s, again, not a magic bullet, but beneficial. And simple meals or snacks available during bouts of depression or mania. And so again, I think that, the mania doesn't sound that bad, but we're talking about an extreme giddiness or excitement where, again, we're forgetting to eat. We have poor self-care, so not bathing as often, not eating, not cooking, etc. And again, one of the major side effects of the medications is dry mouth, so moist foods may be better tolerated. So the treatment plan usually involves a combination of medication and psychotherapy. And so again, a combination of medications including antidepressants, antipsychotics, and mood stabilizers. Again, the common side effects of these meds includes constipation, diarrhea, poor digestion, nausea, weight loss or gain, and dry mouth. So schizoaffective disorder is similar to a combination of the bipolar disorder we discussed in the previous slides, along with schizophrenia. So it's a group of disorders characterized by psychotic symptoms. So psychotic symptoms are gross distortion of reality or losing touch with reality, with hallucinations, delusions, disturbances of language and communication, withdrawal from social interaction, and disorganization of thought. This includes symptoms such as hearing voices, believing people are reading their minds, trying to control them, or plotting to harm them. And so again, hallucinations being very common and usually occurring, again, looking at the mid to late teens, into the 20s and early 30s. So nutrition-related issues, so an increased or decreased appetite, overall nutrition status may decline. Again, obesity may result with treatment due to medication side effects. What did you know? Again, omega-3s. Again, so we've talked about the same side effects, right, for these antipsychotic drugs that we discussed with bipolar disorder. May have a deficiency in folate, vitamin B6, B12, or vitamin D. And again, so the hard thing here is developing that rapport or that trusting relationship with a patient. So again, especially if you're only seeing this patient for the first time versus if you're in a behavioral health unit and working with patients on a daily basis. But so for example, one of the things that I often did when I had patients when I was seeing them in the behavioral health unit was looking at foods that were pre-packaged. And again, it's not foolproof and every patient's different. But instead of food that was, prepared and looked obviously like anyone could have touched it, right? If I just used simple snacks or simple foods, things like twist cap drinks, chip bags, etc., right? Things that the patient had to open themselves, they were commonly better received, but not always. So treatments, again, we said that's antipsychotic medication, psychosocial therapy, substance abuse treatment, and again, so the substance abuse is as a comorbidity or a secondary condition to the schizoaffective disorder. So what you'll see is that substance abuse is very common in this patient population. So if you're having hallucinations, right, you're hearing voices, but if you're incredibly inebriated, right, and you're consuming large quantities of alcohol, then it's very difficult to hear voices, right? So what you're looking at is, in essence, a coping mechanism that, of course, is not healthy. So that's why you'll see that substance abuse is very common. So we're going to need substance abuse treatment, rehabilitation, and then family or group therapy. Now we've talked about, several different times, we've talked about, these mood stabilizers and these antipsychotics. And so one of these side effects, and we've talked about this before, is tardive dyskinesia. So this is a condition characterized by involuntary repetitious movements of the muscles of the face, limbs, and trunk. And so this is caused by drugs that block dopamine receptors. And so this is the long-term use of drugs to treat schizophrenia. So again, looking at our antipsychotics, and this occurs in 20 to 40% of all patients receiving long-term antipsychotic drugs. Now again, that's not the only drug category, but when we're talking about psychiatric conditions, that specifically we're focused on antipsychotic drugs. But this is also caused by motility agents. So we've talked about previously, for example, Reglan and gastroparesis. And so nutrition-related issues, so difficulty eating due to puckering of the lips or involuntary facial movements. So we may need to modify the diet or change the silverware, as the patient may have difficulty feeding themselves with involuntary limb movements, again, due to the side effect from this medication. Now the problem is that it's a dose-dependent effect, which is the more of the drug you take and the longer you take the drug, the more likely you are to develop tardive dyskinesia. And so what you'll see is so remember, this patient population is afraid that people are following them, out to get them, trying to read their minds, and they think everyone's looking at them. Well, if of course you've now developed tardive dyskinesia, it's just the nature of the American population. Now people actually are going to look at them, in which case it's not really in their head anymore, is it? So what you'll see is, especially as once these symptoms start, is that patients may be very non-compliant with their medication, as it creates a very uncomfortable social situation for them. So we'll take a look at OCD, or obsessive compulsive disorder. So an anxiety disorder characterized by recurrent obsessions or compulsions. So obsessions are recurrent thoughts, feelings, ideas, or sensations, and then compulsions are recurrent or standardized behavior. So obsession is something going through your mind, compulsion is something that you're physically doing. And so obsessions and compulsions can become very time-consuming and can interfere with normal routine, social activities, relationships, and occupational function. And so, right, there's a fine line, and again, this is why you don't read the DSM-5 and you don't diagnose yourself. So right now, with this concern about COVID, right, everyone's washing their hands much more frequently than normal. The question is, should we have been washing our hands more frequently than beforehand? Did we just not care? Was it always more important? How many times is it washing your hands before it's a compulsion, washing your hands back to back? But again, right, realizing that it's a lot more subtle than that, right? So again, just because we're concerned about COVID because we've been touching lots of contaminated surfaces, or we've had to do some essential shopping and we wash our hands frequently, that's not really a compulsion, right? You could choose not to do it. But in this case, we're doing it because we know it's the safer option. Whereas a true compulsion, right, you're not going to be able to stop yourself, right? The way I envision it, or try to explain it to envision, is that it's kind of like being on the roller coaster, and once the ride starts, you can't stop it. Even if you want to get off, it's too late. Whereas, right, if you're just choosing to wash your hands because it's out of concern with a current crisis, not the same thing. So nutrition-related issues, so have an increase or decrease in appetite, may avoid specific food groups, overall nutrition status may decline, or obesity may result. The next set of disorders we'll take a look at is ADHD and ADD. So ADD is attention deficit disorder, and ADHD is attention deficit hyperactivity disorder. So disorder characterized by inattention and hyperactivity and poor impulse control or impulsivity. And so nutrition-related issues includes an impaired ability to retain and use new information after counseling. So again, that inability to focus. Again, may respond to omega-3s. And so the side effect of the medications, and this is most prominent in the pediatric population, is, so for example, is that amphetamine-based medications do cause a decrease in appetite. So what you see is this patient population is frequently monitored. So you'll see their weight chart. And again, it's going to be frequently monitored to make sure the patient is not losing weight. Less of a concern in an adult, but again, we know that children really, in essence, should never lose weight. Now, they may have stable weight and not gain weight while they're growing, but they definitely should not be losing weight. So autistic disorder, severe pervasive developmental disorder with onset usually before 3 years old, characterized by impairment in social interaction, verbal and nonverbal communication, and by restricted or unusual repertoire of activities and interest, also referred to as autism spectrum disorder. So currently believed to affect approximately 1 in 88 children, more common in boys than girls. And then again, a secondary issue, so 23% of children diagnosed with autism spectrum disorder develop epilepsy by the time they reach adulthood. Nutrition-related issues include affected appetite, may have increased needs from pacing, strong food dislikes with sensitivity to taste, smell, or specific textures. So this may limit specific food groups. Overall nutrition status may decline, constipation, again, may have improvement with omega-3s and especially DHA. And so what we've seen is there's a lot of case studies and anecdotal evidence for gluten-free, casein-free, or soy-free diets. but no clinical trials have actually shown any improvement with these restrictive diets. Sleep disorders, so chronic disorders involving sleep, they can be caused by medical conditions or secondary to other medical conditions or a psychoactive substance. And so nutrition-related issues, so again, night eating, obesity, and increased appetite. Substance abuse disorders, so again, disorder characterized by harmful or hazardous use of psychoactive substances, including illicit drugs and alcohol. 40% of the US population reports using one or more illicit substances in their lifetime. Now what's interesting though, and so I don't know how much of this you all discussed in counseling, but so when we're taking a look at different behavioral theories, so this is going to sound strange, but we don't actually know why people do drugs. So we have several behavioral theories, including the positive effect of the drug, which is so certain classes of drugs, when you use them, cause euphoric effects, but other drugs don't, so that doesn't explain why people would use the drug. There's psychodynamic factors, such as an inability to deal with reality, genetic factors, so looking at, again, a more compulsive or impulse controlling or a lack thereof in a personality type, or neurochemical factors. Again, we looked at substance abuse as a self-regulation, so for example, with our schizoaffective and schizophrenia disorders. So again, we're not actually sure what causes it, which is why you'll see the treatment for substance abuse varies, but you'll see, so for example, the trans-theoretical model, really the groundwork is in substance abuse. That's why there's such a strong focus on relapse management and prevention. So nutrition-related issues from substance abuse, so during withdrawal, likely to experience nausea, vomiting, dehydration, possibly the shakes or the delirium tremens. Weight gain is common during recovery, so again, as we replace drug use with food intake, again, there's a likely increase in weight. Poor self-care while using drugs or alcohol can previously have resulted in poor diet, malnutrition, weight loss, underweight, or possibly weight gain and obesity. And we know that alcohol abuse, right, causes a deficiency in B vitamins with a focus on B6, thiamine, and folic acid. Elimination disorders. So this is a little bit of a different category, but so we have encopresis, so pattern of passing feces in inappropriate places for at least 3 months in a child that is at least 4 years of age, and enuresis, so repeated voiding of urine into the clothes or bed, so it may be involuntary or intentional, occurring at least twice per week for at least 3 months, and the child must be at least 5 years old. So again, this is occurring in children who are old enough to have control over these bodily functions, but then now due to some psychological issue are not. So whether they're seeking attention, they're having problems adjusting to school, a sibling, etc., right? So this is a behavior or a controlling behavior to gain attention or to establish control. So encopresis occurs when a child resists having a bowel movement, so causing stool impaction, and so liquid stool will leak out of the anus. So again, we said so fear, anger, anxiety. So again, we're refusing to have a bowel movement, again, as a control issue, so we can try and attempt to exert control to deal with these feelings, and then, right, so again, we then have leaking. So 75% of children with encopresis are constipated and have excessive fluid overflow. So it's kind of like there's so an impaction is severe constipation, but there's like small holes in the dam, or the dam's being overwhelmed. So then there's small amounts of stool that are still being passed. So this can be related to psychiatric difficulty or neurodevelopmental problems, may occur during times of stress, or again precipitated by a stressful life event such as moving, birth of a new sibling, or fear of using the toilet. And so the therapy is fluid, fiber, and exercise, and then possibly stool softeners. So again, looking at how long the child resists, or if this is going to be an ongoing problem. Munchausen syndrome. So most people are most familiar with Munchausen syndrome by proxy, but so this is a serious psychiatric disorder in which an individual pretends to be sick or may make up symptoms or push for risky operations and habitually plead for treatment and hospitalization for an imaginary or self-induced illness. And so Munchausen by proxy, which is what most people are familiar with, is where a parent persistently fabricates or induces illness in the child. And so what happens is, right, is that this is the very doting parent. They take the child to all the appointments. so on and so forth. And so this is the there's the Hulu show that just came out a couple months back, that was dealing with basically an extremely, I don't want to say exaggerated because it did happen, but an extreme case of Munchausen by proxy. But for example, there are psychiatric patients, and so the psychiatric patient would take a pencil and stab themselves in the thigh or in the glutes, and then pack the holes with feces, then causing them to get severe infections. So they then would have to then be transferred from the behavioral health unit to the hospital, where they would receive a lot of attention, medical care, etc. But they would then have to undergo procedures, so significant surgeries to clean the wounds. But they were doing all this to get attention. So the mini mental state exam, so I'm going to post, so you can take a look at this. So developed in 1975 by Folstein et al. To determine the cognitive state of patients. So it's a 30-point validated questionnaire that's used to screen for dementia or other issues. It takes about 5 to 10 minutes to administer, but the key is that it should be scored only by a qualified healthcare professional, such as a psychologist, social worker, physician, or a psychiatry trained nurse, as again, it does need to be interpreted with context. And so when you take it, you may find that you get some of the questions wrong. But so for example, there is some bias. So for example, I don't know how familiar you all are with things like equinoxes, etc. But so for example, one of the questions has to deal with a specific date on the calendar in the spring equinox. But in Florida, by the time the spring equinox happens, we just have one temperature. It's hot out. I don't know for most of y'all, but at least for most of this quarantine, I want to say it's been in the mid-80s in March. It is still snowing in some places up north, and yet we're already in the 80s. So then trying to ask me the first day of spring versus the equinox versus the temperature, right? So it has some regional bias to it. So again, some of the questions may have to be, there's different versions of the exam used, so again, there is some bias. But just realize, again, this is why a professional needs to interpret it. But there's categories that focus on memory, arithmetic, language, and comprehension. And so results of the mini mental state exam should be interpreted in the context of history, full mental status examination, physical examination, and lab values. So again, if somebody's baseline is 1 score and they continue to score that way, then again, they may have some cognition issues, but there's actually not a change in status. Whereas if you started off with a proper score and then had a decrease in score, right, then something has changed. So a 27 out of 30 or greater, 27 or greater out of 30 indicates normal cognition. Scores of 20 or lower indicate delirium, dementia, schizophrenia, or a mood disorder. And so just as some fun trivia, if anyone has watched the most recent episode of Grey's Anatomy, this is what Dr. Weber, you actually see him on a clipboard. You'll see him performing the mini mental state exam, which I will also be posting a copy of for you to look at. So here you can see it in the slide, but I'm going to post a full-size PDF. So again, there's your classic orientation, which is what year is it, what season is it, the date, day, and month. Where are we? So state, country, town, hospital, what floor. So registration, so looking at naming specific objects, attention, recall, language, etc. So again, you can try this, if you're bored at home with your family members, you can try this with them and see how they do on the questions. I'm sure they'll do well. So again, you can see here, so the focus, what we're going to be focused on is our major concern. It's going to be, so with psychiatric disorders, is going to be poor nutrition intake. So looking at substance abuse and its interference with proper nutrition intake, a focus on omega-3s, and again, genetic risk. So our practice question, so patients with axis 1 disorders are generally treated. So axis 1 requires answer choice A, medication. So again, these are things we took a look at. These are things that we commonly associate with medication treatments such as ADHD and depression. The primary dietary source of omega-3 fatty acids. And so again, what we're looking at is in the highest quantity and we're going to look at EPA and DHA, and so that is going to be answer choice B, fish. The other key nutrients associated with brain health that we discussed are going to be answer choice D, that is vitamin D and the vitamin B complex. And number 4, the primary responsibility of a dietitian working with individuals with mental health diagnoses is to, and that is answer choice D, impart information and support for eating choices that minimize the negative effects of the illness. All right, so this will be posted. I will also post the mini mental state exam. So there'll be a discussion board that we'll also have for you to post questions about this lecture.